Thank you.
Thank you. Welcome. So today we're going to talk about family medicine, and we'll tell you a little bit about who we are, what it means to us, and basically we want to know what questions you guys have about it. So, like he said, my name is John DeGust. I'm a lieutenant in the United States Navy. I'm a third-year resident in family medicine at Naval Hospital Camp Pendleton. It's located in San Diego County. I attended Uniformed Services University of the Health Sciences out in Bethesda, Maryland. And basically, I chose family medicine because, to me, that's what a physician is. A physician is supposed to be able to take care of any problem, and the only ones, in my opinion, that can truly do that is really a family medicine doc. So we train in all aspects, and then I'll let them tell their side.
I'm actually a graduate of UC Davis and went to UC Irvine for medical school and did my residency in Modesto at what was then a county hospital-based residency. And then ended up back right around here. I actually live and work in Winters, which is about 12 miles west. It's a little community, about 7,000 people. And I went there because that was going to be the perfect place for me to do family medicine. I think of family medicine as has a couple of key things. One is a focus on relationships over time, so continuity of relationships. The other is it focuses on management of what you might call the undifferentiated patient. So the person who walks in the door who has not been labeled yet, who has not been diagnosed, who has a bunch of things going wrong and they need your help to figure it out. And the third thing is health maintenance, health promotion, and prevention. Those, to me, are the big things.
Hi, my name is Pat Moore Pickett, and I actually came to medicine a little later in my career. I majored in anthropology when I was in my undergraduate years. I didn't really think of, medicine was not really on my radar yet. And I did some work in doing blue-collar organizing. A lot of that turned out to be workplace safety protections. And I got to a point where I was, man, I was driving a bus, I was a mail handler, and I wanted a skill that I could feel good about as I was getting older. And I found out that I really liked pre-med studies. As I went back to school and learned my chemistry, my physiology was really exciting. And it was in medical school that I found family medicine as what seemed like the best fit. I think the thing that really excited me in my volunteer experiences before coming to medical school was the power I had to nurture a child in a hospital. I volunteered at Children's Hospital in Oakland, and it was the most meaningful thing to me, is to be able to calm a child who had terrible, painful mouth ulcers. Some viral illnesses will do that. And this child, it was just too painful to drink. So he was in the hospital getting IV fluids. He had his arm taped to a board so he couldn't pull it out, and a pretty miserable experience. And that's where I kind of found my power as a nurturer. And I really thought for a long time I wanted to go into pediatrics, and I'm glad we were introduced as the spectrum of, no, we take care of the mom and the baby, the dad and the family, and we sometimes see how the family works is how we nurture the kids. And more it seemed like I was in tune to the family system, whereas my pediatric colleagues who wanted to go into pediatrics were advocates for the child. And said, well, if you really want to advocate for the child, you need to nurture the parents to be able to nurture the child. So that talked me into family medicine, and we can talk more about how we learn about ourselves in the process of going through our education as to finding what that best fit is. In family medicine, we are the first people that people come to when they've got a problem. And I like it as a challenge of, well, let's see, you've got an ache or a pain. We see a lot of those. You've got an infection. Is this serious or is it common? Are you anxious or depressed? I can't sleep at night, and that wreaks havoc on a lot of systems. Or maybe a family member is faced with a really serious illness at the end of life, and we need to have those conversations. So it's from cradle to grave, and we walk with people through the process. We know when to get help, and we are the people they come back to when the specialists and the procedures have done what they can, and they're faced with, how do we live the rest of our lives with some meaning? So it's where I find meaning in my practice.
Absolutely, and something that that she just said was the cradle to grave. I've always even I like to say the conception to death as well, because I take care of we do prenatal care, we do OB care, we do hospice care, and I mean that's very well exemplified by my residency. Not long ago, I went from hospice to on one rotation. The next month, I was doing pediatrics clinic, and then the month after that, I was doing the labor deck, so I was delivering babies for the month. And I mean, it's a great example of what we do and what we're expected to know and take care of. And then I have patients every single day when I see clinic that come in and are so grateful that I'm taking the time to talk to them and treat them like a person as opposed to just being a patient. And I think family medicine is probably the best specialty for that. Every other specialty is a lot more intellectual, science-based, and really wanting to push the envelope and research. And not that family medicine doesn't do that, but we try to focus on the patient and how much we can help the patient. And every single day I have people thanking me for what I do. So.
And one of the things that's different about training in family medicine compared to, say, internal medicine is that the training, it has to involve behavioral health and family dynamics through the whole couple of years that you spend training. And so we take very seriously that psychosocial interconnection with physical health. And we have given the keys and some tools to help work with people over those things. So, there are a lot of family physicians that actually choose to go to family medicine psychiatric residencies, combined residencies, because there's so much interconnection there. But your basic family medicine training will go through that as well.
I have a colleague who's a family medicine in our clinic who specialized in sports medicine. So we have a nice breadth in our office. There are 5 of us in family medicine. One has done a little more specialty work in gynecology. She does colposcopy. I have a colleague who loves injecting knees and elbows and shoulders. My own philosophy has been that if I'm going to do a procedure, it's got to go as well as it possibly can every time, and I think that means a lot of volume of doing it over and over. So you have to really, really love that. And one of those circumstances, I remember an older woman with arthritic knees, and we're hearing a lot about pain medicine injections. Sometimes there are risks that you wouldn't even imagine. But on this particular woman, I remember trying 10 times to get into a little teeny space. The joint space narrows, and I couldn't get the needle in. It's one of my worst nightmares, is to inflict more pain rather than give somebody some relief. So I've gone less and less and less on the procedures in my own particular practice. And I've really embraced the behavioral medicine, the talking about the end of life, advanced health care directives, the talking things. If somebody needs somebody to explain their medicines, I love that. The procedures, somebody else can do that.
That's one of the joys of family medicine, is that depending on where you choose to go, what your setup is, you can kind of tailor the practice, the things you do, to what you feel like you're really good at and what you enjoy. I do obstetrics and deliver babies in addition to regular office-based practice, and that's becoming a little unusual, but like you were saying, I just, that thing about seeing a mother through 9 months, delivering the baby, having the baby come to me, growing up, I mean, I just can't give it up. It's like an addiction. And I have a young woman in my practice that she was like the 3rd baby I delivered when I first came to Winters. She's a sophomore here at UC Davis. Those things are just, they're just invaluable. They're wonderful.
Yeah, and I personally, I actually really enjoy doing a lot of different procedures. I used to be, when I was in the Coast Guard, I used to be an airplane mechanic. And so I love working with my hands. I love doing as many different things with my hands as I can. And so I do, I'm training to try to get credentialed to do cardiac stress tests, to do every, or at least the big joint injections, and I'm going to be certified to do endoscopies, so colonoscopies and upper endoscopies, and then colposcopy as well, which is kind of the next step on after pap smears, if you guys know what that is. But so I personally love doing all that stuff, and some of my colleagues in residency shy away from that stuff. It just depends on what you want to do. And I think that's one of the amazing things about it that really drew me to family medicine. I actually had an interesting experience in undergrad. I was a reservist, and I've been in the military for 15 years, but at the time I was a reservist. And I was actually working for UC Davis Health System at the Capitol Clinic, which is a family medicine office in downtown Sacramento, and I was basically the call center guy. So I would all the patients would call and schedule their appointments, leave messages, yell at me on the phone when they were upset about something, and every day I went home with a migraine because I was the brunt of any of their frustrations. But there was several different docs there that that basically loved their job. Their patient loved them, and they would do anything to take care of them. And I always respected that about them, even though when I left there, I went to med school, I was like, no way in heck am I going to become a family physician, because I kept thinking about those headaches. And as I went through all my different rotations and all my different classes, I just kept coming back to the fact that, I love everything about medicine, everything. I do my surgery rotation, I loved it. I did my OB rotation, I loved it. I did my internal medicine rotation, loved it. Pediatrics, I was just like, oh, every time I was there, I was like, oh, maybe this is what I'm going to do. And then I did family med, and I was like, wait a minute.
Let's put them all
I
together.
was like, you can do everything. This is amazing. So you do some minor surgeries. And, on top of that, I'll do vasectomies as well. That's minor surgery that family medicine docs can do.
See, that's one I didn't do, because I figured the desire of men to come to a female physician to get their vasectomy was probably low, so I didn't do that one.
Yeah. But women can still do it. One of my staff is a female family medicine physician that does vasectomies. So, right. I just kept thinking about how much I wanted to not give up a specific part of medicine, and family medicine is really the only way to do that, in my opinion.
Maybe time for questions now.
Surgery while you do family medicine?
Yeah, absolutely. I mean, you can be, you're not going to be doing major surgeries, but you can do minor things like vasectomies on your own. You can do, incision and drainage of abscesses, or, excisional biopsies and stuff like that. But you're not going to be doing anything in the belly or.
Well, maybe not. I mean, I have a colleague that was an intern when I was a senior resident. He lives in Alaska now. He does appies, he does gallbladders, he does C-sections. So they're out there. I mean, if it's something that really drives you, you can find the place to do it.
In this area, we have a lot of doctors. This is kind of, we have Sacramento, and we're not too far from Sacramento, so we have access to all kinds of surgical assistance. So it's not as critical that we learn to do everything. So I have a lot more leisure in picking an area that I can focus on if I want to. If I really love that part of surgery, there are lots of opportunities to assist. I know doctors in LA in family medicine fighting for their ability to, when they were delivering babies, they'd recognize that they needed to master the cesarean section surgery, so that they could feel more confident about whatever happened. They'd be there, and they'd be available and skilled to manage that part of it. Not, well, everybody has to make their decision. Sometimes people very skilled at cesarean sections have to call in backup when that goes wrong. Everything has a risk, and you need to know your backup. So it's kind of going where your heart goes is kind of what it comes down to.
And as you kind of discover that through medical school, and you say, well, I love this technical part of this and that, but I want to do family medicine and find a way to integrate that. Then you go out to your residency programs, and you look specifically for residency programs that will give you what you're looking for, because they vary widely. I mean, in terms of what they're focused on, and there are some residency programs that are very much would get you ready to go to Alaska and be the only person there, and then there are some where that just doesn't fit in that say, an urban environment or whatever. But you're going to be very good at you know, ambulatory care of 90% of what walks in your office, and you're looking for more of a 9 to 5, you know, nice practice where you get a relationship with your patients over time. And some people are, I mean, family physicians across the country, a lot of them do emergency room because there's way more emergency rooms than there are certified residency trained ER doctors. A lot of them like urgent care. I don't particularly myself, but a lot of people do. So, and urgent cares love family physicians because we can do pediatrics, we can do internal medicine, and we can do a huge chunk of what, pretty much everything that comes to an urgent care. Some people like that kind of setup.
Yeah, and then on top of that, you can also specialize in more like hospitalist-based medicine, so you don't have to just focus on clinic either. So.
Yeah, one of our colleagues is, I'm sorry, one of our colleagues has become a hospitalist in Sacramento, and I would say her ability to coordinate the care on discharge from the hospital, she understands probably better than even the other hospitalists who are often from internal medicine, the incredible value of being able to coordinate with home health nursing and family support and get that communication and that bridge done well, so that they're not right back because they didn't understand some key thing about, well, when a wound gets really big and red and it's getting worse, you know,
come back.
who do you call and when do you come back? Or oh, I didn't know I had to change that every day, the dressing, or you know, some piece of information. So coordination of care over time is one of the strengths of our.
Can we talk about some of the differences between family medicine and internal medicine?
Sure. Who wants to tackle that one?
So internal medicine specifically specializes in adults. So you can do general medicine, you know, general practitioner, basically in internal medicine, and your practice, you know, one might think looks much like a ambulatory care family physician as well, but you're only going to see adults. So you still will do expected to know some, you know, the women's health stuff, the men's health, you know, the specifics and geriatrics, but you're not going to see kids, and you're not going to see OB and teenagers. You know, you're not going to see that stuff.
Yeah, and in the way things are working out now, we have such a burden of older folks in you know, needing more and more health care as our population ages, that if you're specializing in internal medicine, and particularly if you're doing general internal medicine, which is actually something that it would be nice if we had more of, but they're becoming a very rare breed, your entire day is going to be people probably over 50 to 55 doing diabetes, hypertension, coronary artery disease, COPD, chronic obstructive pulmonary disease, which is great, and there's lots of great work to be done with that. But for me, I need a little bit of something else mixed up in the day there to get me through. So, and the other thing that I tell my med students that come rotate in my office is that the thing that internal medicine training, it's very hospital focused. It really doesn't talk, they really don't do, they do some clinic, but they don't, that's not their main focus. Because the huge majority of people doing internal medicine residencies are going to go on to either be hospitalists or they're going to subspecialize to be rheumatologists, neurologists, et cetera, et cetera. So, so they don't really spend very much time on specifically gynecology, women's health, just a little. And they certainly don't spend a lot of time on the behavioral health piece of it. And I can tell you, those folks that the internists are seeing as outpatients, boy, they, you know, they need that. You know, that's still a big piece of what you're dealing with. And I liked going to a training program that focused on that.
Yeah.
When I went into, when I finished my training and went into practice, I think I did have this sense that when someone's medication list started growing and growing and growing, and when their problem list started growing, so that involved the heart and the liver and the kidneys and the lungs, there was, then, you know, I knew enough to know that all the medications they were taking were interacting, and all of the problems that each failing organ was having an impact on the other organs, and it was becoming more and more complex, that this became a more and more overwhelming situation to manage. And I would look to the internal medicine doctors and say, okay, you're trained in that complexity. And more, as I've been practicing for now 16 years, I see that there's a big overlap. I'm starting to take care of and gain confidence in more of these complex patients, and see what their family support is, understand the need for keeping their medications affordable, making sure that they just get the procedures they really need, understanding what parts of their care are most valuable to them medically. But there's another key difference I see in the training of family docs and internal medicine docs, and that is our reliance on figuring out a problem over time. So we are attuned to what is normal, what's a variation of normal that may seem abnormal, and what is commonly experienced, like diabetes. We recognize those and are very comfortable with those things: heart disease, strokes, infections. Whereas internal medicine, I think they're trained to have a differential diagnosis in their head. So if somebody comes in with dizziness, they've got a long list of things that they know it possibly could be, including pheochromocytoma. And they've got a long list of lab tests that they need to do to get it diagnosed at the moment. Whereas I know I can, because I depend on that continuity of care over time, I know to hit the most common things like pregnancy, and then get to the pheochromocytoma when the most common things have been ruled out. So there's a different approach to a problem, which suits my psyche a little better.
I think, and another way to kind of think about it is breadth versus depth. So a family medicine physician is expected to know, at least a little bit about almost everything. And an internal medicine doc tends to know some very in-depth, into the weeds stuff about some of the more complicated diseases. And it definitely has its place, but there's each person probably has their somewhat maximal potential for how much you're going to be able to retain at any given point. And bottom line is you just need to be able to choose which one you want to do. Do I want to know a lot about gastrointestinal diseases and become a GI doctor, or do I want to know at least enough to know that my patient needs to see a GI doctor, and that I can manage the basic problems and and some of the more complicated ones, and then say, you know what, that's a little beyond my scope. I need to send them to see the specialist, which is with the new national healthcare system and stuff. That's one of the things that we're trying to get back to, is people not having to see the specialist when they don't need to, and have a primary care doctor that can basically say, yeah, no, I can treat that because it's probably not that pheochromocytoma. It's probably something just that you have really high salt intake, and that you need to manage your diet a little bit better, and lose a little bit of weight and exercise. And if you do those things, it's probably going to work out. So it's really the focus is different, I would say.
Go ahead.
So is family medicine competitive? What is the demand of family medicine now?
So family medicine is something that we have a big shortage of, okay? So there's a shortage of family physicians. Yes, believe it or not. And the demand for it is growing all the time, because as we look as Americans and we look to other countries and we want to revamp our healthcare system and get much more value for the money that we're spending on it, we come to realize that like we always do things, try everything else and do the best thing last. But come to realize that every other country has realized that we need, that a system works the best if they have something around 50-50 specialists and generalists. And we are nowhere near 50-50 specialists and generalists. So, and there's a big cost savings to the system if we kind of somehow get there. So all these, Sutter, I work for Sutter, but it doesn't matter whether you work for Sutter or UC Davis or Kaiser or by yourself or whatever, there's a definite demand for for this kind of services, and it's definitely going to be the growth industry
Yeah.
in medical specialties, I'd say.
When I was a first-year medical student, it was the first time I had that kind of fleeting thought, maybe I do want to be a family medicine physician. I said it to one of my friends, one of my classmates, and he said to me, he's like, "But there's no money in that." And I was like, "Excuse me?" Like, I'm like, we just started 6 months ago, and you're concerned about your paycheck already. Like I think you might have gone to medical school for the wrong reason. Like, I didn't go to medical school to make $500,000 a year. I went to medical school to help people, and most people say that. The ones that really mean it should think about family medicine. I want to do everything I can to help my patients. I go above and beyond sometimes to to my wife being a little bit irritated that I'm not home at 5 and instead got home at 5:30 or 6, and she's like, again, you're late. But she always respects the fact that I'm helping my patients. Last night was a perfect example. I came home late, but that's because one of the kids I saw 2 days earlier was getting admitted for about a month old and now has a fever. And I saw them, they just kind of had a upper respiratory tract infection, but didn't have a fever yet. And you have to admit those patients. You have to do a big infectious workup on them. And so I stayed late to kind of help the mom out a little bit. She was kind of distraught about it, and the admitting team was come down to do it. And then all of her family was sick too, and they're all prone to getting asthma and stuff. So I put in some a steroid prescription for her daughter who was getting an asthma exacerbation, and I took care of all that. And I told my wife about it, and she goes, "Fine, like you're right. Like I'm glad you did that." And she always brags about it, and she loves the fact that I'm willing to do that. And I didn't get into this specialty for the money, but it's not going to pay me bad either. Like
right.
I'm going to make plenty of money. You're still going to be in the top income earners because you're a physician. You make a decent living as a physician regardless of what specialty you go into. So I'd say that should be the last thing on your mind. You should just be going into the thing that you love, because that's the only way that you're going to be happy doing it.
I would say this is kind of an exciting time to think about family medicine because we are on the cusp of some big changes in terms of reforming how medical care is done in this country. And whatever you might think about the Reform Act, everyone is starting to plan for that. And it has put some emphases on prevention of care as being where the real value is. And up until now, I think there's been a real skew toward the procedures. So the people who did the procedures got the most money. The people who just merely talked to the patient didn't get as much money. So there's been this disparity, which meant that people worried about paying off their medical, their
Loans
school loans. It's like, well, I want to go here because now I have this big debt. And so medicine, family medicine would be last on their list. But they're starting to take a look at this because just procedures is not always where the most benefit is in terms of what that person should be going through in terms of getting through their illness. Now, I will say that I am grateful for every person who did a procedure that helped cure my patient. But I don't want my value undervalued in terms of making sure they got their shots, that they understood how to prevent a situation in the first place. Like, I'll put my heart and soul into helping somebody quit smoking if they're ready to do that. Some of these things I really had a thought of, in a health fair. I said, oh, they're going to tell me to eat my vegetables. Oh, God, oh, I got to go walking. And, it's sort of, how do I reframe that in a way that helps people take care of themselves? And it's gotten more exciting.
It takes a lifetime of practice to figure it out and to get good at it.
And sometimes it's like, I'm sedentary too. I love nothing better than to sit down and read a book. That's where the stories are. And that's why I'm in family medicine, because I love hearing about people's stories. So we share what we like doing, and we figure out, all right, where are our motivations? You want to lose a little weight? Great. You want to make sure that you stay as mentally sharp for as long as possible. Great. These are reasons to get out, maybe walk an hour every day if you can. You know, what do you think your goals are, and helping people figure out their goals and supporting them in that. That's motivating for me, if I can figure out a way to get them the confidence and the satisfaction of doing that for themselves. So I want that value, and I think that is starting, that tipping of the scale is starting to be seen as actually more valuable than a lot of the procedures done. We don't need mammograms every year necessarily. We used to do pap smears every year, screening for cervical cancer. We don't need to do that necessarily every time. We are on the cutting edge of figuring out what are the most valuable things in a preventive exam. Does it need to be an EKG every time you come in? The Cadillac workup? Actually, no. And that's exciting, because I don't like, you know, as a potential patient, the biggest fear is the pain around all the procedures that I have. So if I know where the value is, I can help talk somebody through that or help them avoid that if we can.
Other questions? Yeah, quite a bit more time. Yeah.
No one else?
No, go ahead.
Go ahead, go for it.
Is there any PA in family medicine? Is it common to see that?
Oh, physician's assistants?
Yes.
Yeah, yes, there are. A lot of family physicians work in teams, and I think this is going to be the wave of the future, is working in teams with nurse practitioners and physician's assistants. One of the big kind of cool things in primary care right now is patient-centered medical home, or this idea of taking a group of people, working with a panel of patients. Not all of them may be in your office at any one time, but they're out there in your community, and you are kind of, your office is in charge of taking care of them. And using this team of people and divvying up the work, you're not only wanting to see the folks that have decided on their own that they need to come in to see you, but you also want to be able to look at lists of patients. Who are my patients that have diabetes? Have they been in a while? Have they had their hemoglobin A1C checked in a while? No? Okay, let's get on the phone and get them in here. You know, so there's a lot of work to be done that's not necessarily MD work, but a lot of work to be done to kind of manage populations and groups of people in a much more proactive way. And it's going to be exciting to kind of, you know, grow these teams and work together to do that in a much more proactive way than we do now. Right now, our system is pretty much designed for, you decide you have a problem, you access us. And that is, so it's an acute care and emergent care kind of system, and we want to see our healthcare system change to something that where we have an idea of who's out there, what they need, and we're actively helping them get it.
Yeah. You know, the majority of the dollars, like medicine dollars that are spent on any given one person, is generally in the last decade of their life. When they've, you know, their chronic medical problems have basically become very severe problems. So if we can help prevent that by preventive medicine, then we're basically gonna, you know, we're gonna extend the life of that person. We're also going to decrease the cost associated with that. So the healthcare system is not burdened with unnecessary things. So you know, that's our role with in the grand scheme of things on a national level. That's what physicians are trying to do, is help prevent, you know, the rising costs of healthcare. And if you can really master preventive medicine, then you know, that's going to be the best way to do that. So that's, family medicines or doctors are pretty much uniquely positioned to kind of take the lead role in that.
So we have 10 minutes. We have other questions. Yeah.
How do you start helping families in need?
How do you start helping families in need? You want to tackle that one?
Really, I think it really depends on, you know, what they're in need of. I think if you're, you know, if you're talking about opportunities to volunteer and do stuff, there's all kinds of organizations around that you can help with. You know, there's, I know in Sacramento they have a food bank. Basically, it's called Loaves and Fishes. You know, I don't think I said this before, but I actually attended American River College and came and helped with this conference when it was first getting started. And then I went to Sac State and graduated from there before I went to med school. So I'm very familiar with the area. And but you know, there's a lot of different, you know, organizations out there. There's a ton of student ones that can help you get involved with helping people that are in need. And then family medicine physicians, you know, I think in general, that's pretty much what we do on a daily basis. So, you know, how to get started with that, I'd say look for if you're still a student right now or not, you can still go to attend a lot of these student organizations and find out what opportunities that they have to be involved.
Yeah, I could tell you one of the values of being in a community for a long time and making these relationships, these long-term continuity relationships, is that people will often come in for just reassurance and if they're in a stressful time of life. And I'm not giving them any medication. I'm not you know, doing anything dramatic or heroic or anything like that, but they know I was there and they can come in and they can basically just cry on my shoulder. And there's a huge therapeutic value in that. There's a therapeutic value at the moment that it's happening and you know, they kind of feel better and you have a hug and you're done. But there's just a therapeutic value of knowing that you're there in the community and that I'm your patient and you're my doctor and that you can have that relationship. You know, I think that even us physicians living it, we sometimes underestimate, you know, the effect we have, just our presence there, how good that is for the community.
Did we get at maybe some of your question? I think some other things might be if a family bringing in their 3 kids, if we're talking about their nutrition, then we try to understand as well as we can what their resources are. And that's where if you've got a school that's got a good public health component, you can kind of see what they're up against in their community. So that if you acknowledge some of the challenges they're up against, like you go into Food for Less and they've got sodas up to the ceiling on either pallets of sodas up to the ceiling as you walk in, and that seems like a cheap way to get something to drink, is drinking these sodas, and yet we have malnourished, obese children growing up in this family. You can kind of help them create priorities of, if we want their nutrition to be better, maybe we just off the soda and onto milk and water if they're thirsty. We could start advocating for supermarkets better placed in our community, but that's more of a public health thing. There are a lot of patients that come in and can no longer afford their medications. They're embarrassed to tell you that no, they actually haven't been taking their blood pressure medication because it's really expensive. Or they look at their medicine and they want your help trying to figure out, are there any generics, or do I really need this medication? Is there anything they could do without? And you can help them with that. I have some patients, actually I am doing more medicine over the phone because they've had to get insurance that has a high deductible. So they have to pay a whole lot of money out of pocket before their insurance actually even kicks in. So it's incredibly expensive for them to come in for an appointment in the earlier part of the year. So some of that we'll do over the phone until they can afford to come in. I mean, you walk with them and it's uncomfortable. It's like, your thyroid really needs help. You really do need to take that medicine. Okay, maybe I don't know what else. Maybe this medicine is not so important. Yeah, we can do a substitution here and that'll save you some money. You know, we have conversations like that.
Got 5 more minutes it looks like, so this is your big chance.
I'm just curious, can you describe maybe an average day for you guys, if average is a proper term for it?
Yeah, every day is very, very different. Especially for me, because I do a lot of rotations right now, so I'm still in training, so I'm getting to do different different specialties. But then I also have my own panel of patients that I'm expected to see. So I have a couple of days of clinic each week. I go rotate with these different rotations, and then I have call nights where sometimes I'm working on the OB deck. Sometimes I'm taking care of admits for the hospital and all the inpatients in the hospital. So it really depends. But on an average day, if I see clinic, I'll see 1 or 2 well child visits. Some of them are newborns. Some of them are teenage, like sports physical. Do a well woman's visit as well. So pap smear if they need it. Just all the normal woman's health stuff. And then I'll see somebody, usually somebody that's elderly, and take care of their blood pressure, their diabetes meds, their, if they have thyroid medication, and I usually see a couple of acute visits in there as well. So they come in complaining of a sore throat, cough, doctor, what can I do? Or like, hey doc, I've been having chest pain. It's like, that shouldn't have been scheduled in 15 minutes, but that's
anyway.
but I'm going to take care of it, and find out what what they need to do, and basically, I mean, every day is completely different, every single day. Sometimes on something that should be a simple visit, a nice 1.5-year-old child. Wait a minute, they're not meeting their developmental milestones and they're not able to talk yet. They're only saying 1 or 2 words. What do I need to do about that? And it seems like those kinds of things come in spurts for me. But so every day, every month, totally different.
I have a totally fun life. I do patient work in the clinic out in Winters 3 days a week. I have a certain amount of administrative time to manage a family medicine department of 165, well, not all physicians, PAs, and NPs. So I'm kind of doing administrative leadership type work with my medical group, and I'm seeing patients. And then I have a whole universe of kind of organized medicine, politics stuff that I do kind of outside of all of that, which keeps me online and interested in all the latest and greatest stuff that's going on in the policy world in medicine. So one of the things I think is really neat about family medicine is because we're focused on kind of global thinking and seeing the big picture, is that family medicine physicians make wonderful leaders in medical systems and hospitals and all of these kind of groups, and you meet the most fantastic people because they all have kind of this orientation and this outlook. So you work with fantastic people, and you have an interesting life too.
Yeah, a lot more it's in the clinic, but I also have messages from the hospital about every month now we're getting ethical cases that I get to convene a group of people who are by design not all the same. So we have a nurse, we have an ethicist educator, we have a pediatrician, we have a social worker, we have a lawyer, and we will all convene and go through an exercise of trying to sort out what has been presented to us as an ethical dilemma, which often revolves around conflict about what is the best thing to do. What if we don't know what the best thing to do is? Often doctors are not as good as they'd like to be, and it is still the holy grail of diagnosis, is when someone is failing toward the end of their life and frail, what are their chances of survival? If we knew that, then we could advise people a little better. Well, sometimes by the time somebody's 80, they have definite opinions about how much intervention they're willing to suffer through in order to have what kind of life. And when people haven't had those conversations or haven't been able to see ahead and sort that out, the families are distraught and not really sure what's the best thing. Do we pull the plug or not? We can step in and help with communication. At this point, a lot of times it's kind of after the fact and helping departments talk to each other. And we have a really great hospital where that kind of effort, that's where my anthropology, I think, kicks in. It's like the anesthesiologists really have a different approach and a different culture than maybe you have in the birthing center or in the emergency department. And helping groups of people talk to one another is kind of, I almost work in the clinic, so I get to do that,
Squeeze in one more question. What type of volunteer work were you guys doing while you were going to school, if you were doing volunteer work while going to medical school or getting your bachelor in science?
For me, I was doing a lot of work in the military still at the time, so I kind of included my time in the military as sort of service to the country. And so I was in the Coast Guard. I did like drug interdiction deployments down in Central America, and And so lots of fun, interesting things like that, but search and rescue missions, that kind of stuff. So that was my community service that I kind of included on there. And I would try to do as much as I could along with the different pre-med groups that I was organized with. So it was a little more restricted for me, but as far as, to one more specific area.
I volunteered at the VA hospital in Martinez, which doesn't exist anymore, but there are other VA hospitals out there. and I learned a lot there, and that was probably a very important thing in my deciding that, yes, I do want to be a doctor, I do want to be with patients.
I volunteered at the Children's Hospital in Oakland, and where I met that cute little kid who was, got an IV hydration going through his arm. But my favorite part of that experience was actually working with what they called the Asian clinic. We had Southeast Asian immigrants new to the Oakland area, and a lot of them needed TB tests. So I got to go out and read their TB tests, but also see where everybody lived and be in the clinic when they came in for their well child visits. And so it was extremely interesting to see them as part of the fabric of Oakland.
I think we're probably done now, huh? Okay. Yeah. Well, thank you very much, guys.